And now I have the pleasure that at the stage with us, we have Professor Ines Abdel Halim, who is a parliament woman member at the Egyptian parliament. She will present the next speaker.
Thank you, Professor Lobna. And now for Professor Matti Aapro, Director of International Society of Geriatric Oncology and the President of Multinational Association of Supportive Care in Cancer from Switzerland, talk about BRCA 1-2 mutation in breast cancer, data from new adjuvant and metastatic trials. Discussion will be at the end of the session.
Thank you very much for the introduction. I will have to apologize. I have been asked to be at 3:30 at another session, so I will not be able to stay until the end because of this. It was not planned, of course. It's a great pleasure to participate in this joint session of the European School of Oncology along with this fantastic meeting. We are very grateful that the organizers accepted the idea that Fedor Peccatori and myself put forward, knowing that we would have the support of Banu Arun for this session, and we are very grateful that she accepted to be the first speaker. So my role here is to discuss with you about the BRCA mutation in breast cancer, and the title was From Data from Neoadjuvant Metastatic Trials. I suggested this because a very dear friend of mine, Professor Hope Rugo, had given at my request a very similar talk, concentrated on triple negative in general, but also looking at BRCA positive tumors in a meeting that the European School of Oncology organizes at the end of November every year for the last 4 years. The next one is planned at the end of November next year, either in Milano or in Rome, and my co-chair for this meeting is Joseph Gligorov, that you had the pleasure to meet yesterday. You already know what is on this slide, i.e. that triple negative comprises quite a few tumor types, and we are starting to define better and better what they really are and what implications for treatment they might have. But we also know that we have a certain percentage that are not really triple negative. If we start to look at them with molecular tools, we realize that they are somewhat more defined. And this is one of the points that we are putting forward in the discussions today, even though they have no direct, immediate implication for the decision-making process. And as you saw from one of the introductory slides of Banu Arun, BRCA mutations are extremely frequent among the triple-negative breast cancers. And depending on the series, depending on where you are, will comprise about 30% of the triple-negative tumors, depending also on the population age that you're looking at. BRCA mutation patients will have either strong family history, but some of them will not have it. What we do know, and what is the focus of this particular talk, is that there is a difference in sensitivity to our cytotoxic agents among BRCA triple-negative tumors. And we do have some historical data about temozolomide, an agent that has been somewhat forgotten in the use with these types of tumors, and the platinum derivatives. And we should never forget that also the alkylating agents, and among them cyclophosphamide, can play an important role in these tumors. We do have some data to show that anthracyclines are not that effective, and then we have had the discussion about taxanes, and I will come back to this. Then we have, of course, data on new agents that are being studied, but for the time being, nothing is available for clinical usage. This is a table from a very nice paper that I would recommend that those of you interested in this particular field give a look at, which was written by Kalasani and Livingston in The Oncologist in 2013, discussing also a point that was made so relevant yesterday by Banu Arun about BRCA-ness, BRCA-ness. So, question. You have a patient who is BRCA positive and you want to decide on the chemotherapy, either in the adjuvant or in the metastatic setting. Do we have enough evidence today to say what is really the way to go, besides the fact that many of us are convinced that anthracyclines might not be the best approach for these patients? To me, this is, at this point in time, a little bit like the search for the Graal. The search for the single agent has worked in some settings. In settings where we really know what the driver is. But here we don't know what the driver is. We know that there are some particular sensitivities in these BRCA-positive tumors, but we don't know which one of the different agents that we could suggest are going to be the ones that are going to be clearly important for these patients. Neither do we know how to sequence them or how to combine them. And I alluded to yesterday to a slide that was put forward years ago in a meeting by Norman Woolmark, so I'll share it with you right now. This is it. This is another way of looking at the fact that tumors have different pathways that will influence or will not influence them. And then we have to block not one, not two, maybe 3 to 4 of these pathways. And of course, the map behind here is, as I said yesterday, the Tokyo subway map. It could be the subway map also of another big city. It just means that we have a lot to learn. We are learning, but we are not there yet. And this is one of the points of discussion, is that all the tests that tell us that we might be able to use them in order to define in metastatic setting what is the best way to treat the patient have yet to be fully validated. And this was a clear position at the ABC3 meeting by the majority of the panel. We have refined a little bit the approach. And one of the refinements that has been introduced, and here's a paper that was published in JCO in 2015, is to look at some of the biological modification within these triple-negative tumors, including the BRCA1 defective tumors. And there are some indications that maybe we can, with some of these scores, refine a little bit more our approach, but this needs to be verified. I will show to you some data of the German group that also looked at this type of score in the adjuvant setting a little bit later. Historical data are presented here by the BRCA and Silver studies, which were some of the studies, not forgetting a study which most of us never cite, and I do not have here the paper for it because it is actually impossible to obtain it from the internet. Professor Kolaric, in what used to be Yugoslavia at the time, was, in my eyes, the first person ever to show that platinum derivatives were efficacious in breast cancer, not specifically in BRCA positive, but in breast cancer in general metastatic setting. So these data showed, BRCA and Silver, among others, that indeed in the setting of BRCA positive tumors, there is an increased sensitivity to platinum-based treatments, and you know all of this. I put, of course, a question mark when 2 out of 2 responders in the Silver study are called 100%. I think it just means that 2 out of 2 responded. In the metastatic breast cancer setting, we have a recent publication that was written by Isakov and colleagues that relates to the study TBCRC009. This is a study in metastatic first and second line patients, the majority of them being in the first line setting, who were then treated either with cisplatin or carboplatin, this decision being that of the clinician treating the patient, along with the patient, I hope. And they received either cisplatin 75 milligrams per meter squared or carboplatin AUC 6. The response rates you can see on the left-hand side, but when you differentiate these patients, and this was prospectively built into the study, into BRCA1/2 positive patients, only 11 of them, the response rate is clearly much, much higher than those that were wild type. Then we have, in the neoadjuvant setting, a considerable amount of studies that have looked at different types of treatments and approaches with or without platinum derivative. In this case, we have the data here for carboplatin. And you know that these data have all shown that there is an increased response rate for carboplatin in these different scenarios for these patients. And the question has been then been asked is how can we differentiate and which are the patients that are actually going to respond? A meta-analysis taking into account these studies has also been published. This was in Breast Cancer Research and Treatment 2014. And this meta-analysis has shown that indeed the platinum-containing combinations are of interest in the triple negatives, and we take by inference and from the studies that I presented to you before that indeed this is true for the BRCA1 positive patients. And so we thought that everything was relatively crystal clear that we should be applying platinum salts. The TNT trial in the metastatic setting, presented by Tut at ASCO and since then published, is here. If you look at the BRCA1/2 status patients, this study which compared platinum, carboplatin, in other words, to docetaxel, showed that indeed those patients that had a germline BRCA1/2 mutation had a much higher response, as expected, to carboplatin. So it confirmed what all of these smaller and sometimes retrospective analyses indicated. So we thought, aha, so here's the answer. And those that had a germline, a non-mutated BRCA1/2, had a very similar response to either carboplatin or docetaxel. And then the debate was, what is the relative toxicity of these two agents for these patients, and what is the decision-making process? Now, looking at the score that I alluded to earlier, you have the data here on the right-hand side. In this particular study, there was no differentiation possible through this particular score. So what we were hoping for was not confirmed in this particular study. Coming to the study that was already alluded to yesterday by Dr. Avararun, we have the Gipper 6 study, which is here. And here again, as I said, they did an evaluation for HDR score high, and they showed that the carboplatin addition was improving in the setting of the neoadjuvant treatment. The other one that I just sorted to was in the metastatic setting, made a difference for these patients. And in their hands, the BRCA mutation patients did have some advantage, which did not reach statistical significance with the addition of carboplatin. PARP inhibitors are under study again. As you know, there have been some early data to show that true PARP inhibitors do work in BRCA1 positive patients. And now we have several studies that are ongoing. Here's one study with rucaparib that shows that indeed in BRCA mutated patients there is a higher response rate in those patients that receive cisplatin and rucaparib. And you have two major studies that are ongoing, one called Brightness. I love these acronyms of all of these studies. Brightness, and the other one is Olympia. One of these days we'll be out of acronyms, but for the time being we have enough names that we can use. And both studies are going to be asking the question whether either veliparib or olaparib do add something in the adjuvant setting for BRCA1 positive patients or in the neoadjuvant setting. So the bottom line of all this discussion was, before San Antonio breast cancer meeting, that we do have some advantage to using platinum, that there is some toxicity increase, but if you compare it to docetaxel, we have to make a differentiation between the types of toxicities. The data supports the use of platinum agents in BRCA-positive tumors. Which ones exactly is a debate that is ongoing. And then we were waiting for the survival data. And the targeted agents for the time being are experimental. They are not commercially available for our usage. And then, as shown yesterday, we had CLBGB 4603, which was presented by Dr. Sikov and colleagues. And here the data, carboplatin or not. Increased response rate, but no impact on patient survival. Hazard ratio 0.84, p-value 0.36, in the study that had about 200 and some patients in both arms receiving either carboplatin or no carboplatin. So quite similar results. And we had then the German study. And the German study showed this difference. And as Gunther has already stated, and Ben-Arun has also stated, there can be all kinds of explanations on why these two studies have different results. But in the German study, indeed, there is a difference in terms of advantage for carboplatin in the triple-negative patients. And this is true by BRCA status. In the BRCA status patients, also the carboplatin-treated patients have a better survival. So, after San Antonio 2015 and waiting for results that will be discussed at EBCC in a couple of months from now and then at the ASCO meeting, we do believe that, yes, we should seriously think about platinum agents in BRCA1 positive patients, but we have some doubts whether they're really going to affect the patient's ultimate survival. And for the time being, we have no new agents to discuss with you. Thank you very much for your attention.
Thank you, Dr. Mata.
We still have 5 minutes because he's
Okay.
we can make an
Okay, we can make an exception for question to Dr. Matti as he will leave. Okay, the floor is for 5 minutes. Okay, Dr. Tahir, please.
Excuse me.
I'll repeat your question. The mic is coming to you.
We treat, basically, recently we published a small study on cisplatin, docetaxel, and local advanced breast cancer. It is about a week ago. And so far, maybe we are the largest in the region that we treat with the platinum-based, more than around 300 cases. And I can tell you, that using the platinum, I am not talking about BRCAs, but I mean that especially in locally advanced, especially in triple negative, the toxicity has not been increased above the side effect of docetaxel. That the combination of the two may be equal to docetaxel in terms of the side effect, either nausea, vomiting, peripheral neuropathy, and febrile neutropenia. And we have 11% of febrile neutropenia who require admission either on docetaxel or cisplatin docetaxel. So don't worry about the issue of the toxicity if you believe in it. I strongly believe patient local advanced, triple negative should receive platinum based. Thank you.
Thank you very much for your comment and also for leading these important studies. I don't want to be misinterpreted. It is comparing agent to agent. We have had data, and I think one of the groups which pioneered this was BCRG when I was participating there, when we associated carboplatin and docetaxel, and actually that was then derived into the adjuvant treatment, TCH, that was just discussed by Dennis Lehman again at the San Antonio meeting. So no, we do agree that we can combine, but when you have a choice for the patient of single agents in the metastatic setting, if you follow the guidelines that say that you should go through single agents, then you have to compare the toxicities. And docetaxel is more difficult to give in that setting than carboplatin. Quite a few patients rather start with carbo. Yeah, no, I know. But that was talking metastatic. Any other question, comment? So his dose is 75, for those that don't hear, 75 milligrams per meter squared for cisplatin and 75 milligrams per meter squared for docetaxel.
Dr. Mata? Dr. Mate, sorry. In Egypt, we're facing a problem. Triple-negative breast woman presented in young age with aggressive behavior. So if the patient presented with locally advanced, in clinical practice, shall we stick it to a standard or to integrate platinum in new adjuvant setting?
One of the aims of the neoadjuvant treatment is, of course, to help the surgeon. As we know that the response rate is clearly increased, that is beyond any debate. I would suggest that yes, and until we can solve the question about whether there is a really long-term effect or not, with the debate between the two types of studies, whether we are on one side or the other of the Atlantic, that could be secondary for your patients. So in our center also, in these patients, we do associate platinum derivatives.
Thank you, Dr. Mata, for your again presentation. Sorry, Dr. Nadia? Dr. Nadia Mukhtar?
Thank you. I was just curious whether in the triple-negative tumors, do you have any role to test for an androgen or anti-androgen therapy role?
There are indeed, and if you're asking the question, it shows how well aware you are of this question. There are indeed data on the use of anti-androgen agents in this small subcategory, and these are starting to be so convincing that quite a few people are now suggesting that we should test these patients for that once they are beyond the first line of treatment.
Thank you, Dr. Mata, for your presentation. Now it's honor and a pleasure to introduce Dr. Vedro Bicaturi from Italy. Dr. Bicaturi is a director of fertility and the procreation unit, Division of Gynecological Oncology, Arabian Institute of Oncology, Italy.